Greetings from IJA. I, Dr. Kiran Mahendru, will present an original article published in the January 2025 issue of IJA. It is on relative perioperative analgesic efficacy of single-shot serratus anterior plane block versus the thoracic paravertebral block in breast and thoracic surgeries, a systematic review and meta-analysis of randomized controlled trials. The immediate postoperative period after chest wall surgery is often associated with significant pain, which leads to development of chronic pain in 25 to 60% of the patients. Thoracic paravertebral block has been proposed as the primary choice for major oncological breast and thoracoscopic surgeries. The technical complexity and higher risk of block-related complications have prompted the researchers to explore a safer alternative. Therefore, ultrasound-guided facial plane blocks have emerged as a promising option due to their ease of learning and execution and low risk of block-related complications. The serratus anterior plane block, that is, the SAP block, is one of the regional analgesia techniques which is simple, safe, and effective for postoperative pain. The deposition of the drug is done either superficial or deep to the serratus anterior muscle at the level of fifth rib in the mid-axillary line. The analgesia is achieved along the anterolateral chest wall by blocking the intercostal nerves, the long thoracic nerve, and the thoracodorsal nerve. The consensus on comparative efficacy of these interventions remains lacking. Therefore, a systematic review and meta-analysis of randomized controlled trials comparing the analgesic efficacy of SAP block with the thoracic paravertebral block in adult patients who have undergone breast and thoracic surgeries was done in this study. The trial is registered with Prospero. It is a systematic review and meta-analysis of RCTs done in patients aged more than 18 years undergoing breast or thoracic surgery. The intervention group was the patients who received a single shot SAP block, either superficial or deep. Trials were excluded if a continuous technique with a catheter was used or performed in combination with other blocks. The authors combined the groups if the trial authors evaluated either approach of SAP block as a separate comparator. The comparator group was patients receiving thoracic paravertebral block. Trials were excluded if any other block was administered along with this block or if a catheter technique was used. The primary outcomes was the time to first rescue analgesia, and the secondary outcomes studied were opioid consumption in the 24 hours postoperatively, intraoperative opioid consumption, pain scores both static and dynamic at early, that is 4 to 6 hours, and late 24 hours intervals, opioid-related side effects, patient satisfaction with the pain control, any adverse events reported in the trial, and the length of hospital stay. For the eligibility criteria, RCTs comparing SAP block with thoracic paravertebral block for analgesia for thoracic and breast surgeries were taken. No restriction was on the language or publication date. The studies that were non-RCTs and RCTs that did not involve breast or thoracic surgery were excluded. The search was performed from the databases from inception until September 2023 and again updated in November 2023 to look for additional trials. Search terms encompass topics including serratus anterior plane block and paravertebral block and breast or thoracic surgery. Data extraction was done on the study characteristics and block details and the reported outcomes, which included postoperative pain scores, perioperative analgesic regimens, time to first analgesia, consumption of analgesics at different time intervals in the postoperative period, functional assessments, block-related complications, and side effects related to opioids. The risk of bias assessment was done using the ROB2 tool. Publication bias likelihood was estimated using funnel plot and quantified by the Eggers test. Data was analyzed using Review Manager version 5.3 and forest plots were generated to visualize the treatment effects. Coming to the results, A total of 18 RCTs were included for the meta-analysis, which included a total of 1,141 patients, with 587 receiving the SAP block and 554 who underwent thoracic paravertebral block. Now, 13 of the 18 RCTs were at low risk, 2 had some concerns, and 3 were at high risk for the bias. Graphic funnel plots for data of included studies regarding the incidence of time to first rescue analgesia for breast and thoracic surgeries were constructed, and both the plots seemed to be symmetrical, and the Eggers regression intercept suggested that the possibility of publication bias was unlikely. Coming to the result, the primary outcome was the time to first rescue analgesia. As can be seen from the forest plot, there was no significant difference observed in the time to first rescue analgesia between the thoracic paravertebral and the SAP groups. However, when this pooled data from patients undergoing thoracic surgery was assessed, it was associated with a significant difference in the time to first rescue analgesia with a mean difference of 0.6. Now, coming to the cumulative 24 hours oral morphine equivalent consumption, there was no difference in the outcome between the two groups. And as we can see in the thoracic surgery patient groups, there was a statistically significant difference in the oral morphine equivalent consumption in the thoracic paravertebral group compared to the SAP group. Now, this is the difference in the area under the curve for pain severity at rest. The mean difference in area under the curve for resting pain scores showed that thoracic paravertebral block was better for breast surgery and for thoracic surgeries. The dynamic pain scores assessed at various intervals, there was no significant difference between the two groups. There was no difference in the intraoperative fentanyl consumption between the two groups, and there was no difference in the postoperative nausea and vomiting. 2 cases reported were of pleural puncture in the thoracic paravertebral group. 5 cases developed hematoma, and 6 patients reported pain at the puncture site in the thoracic paravertebral treatment arm. No complications were reported in the SAP group. Now, this systematic review and meta-analysis observed that the efficacy of the SAP block and the thoracic paravertebral blocks in patients undergoing breast and thoracic surgeries had no significant difference in analgesic-related outcomes. Thoracic paravertebral block exhibited a significantly longer time to first rescue analgesia, that is 41 minutes, reduced 24 hours opioid consumption, and an improved area under the curve for pain scores at rest for patients undergoing thoracic surgeries. The strength of evidence was moderate due to considerable statistical heterogeneity, and these results should therefore be interpreted with caution. Block-related complications like pleural puncture and hematoma were solely reported in the thoracic paravertebral block, and no complications were recorded in the SAP group. A previously published network meta-analysis comparing the active regional techniques for thoracoscopic surgery also indicated that thoracic paravertebral is superior over the SAP block. The findings of these meta-analyses align with this analysis, emphasizing that thoracic paravertebral block superior analgesic outcomes post-thoracic surgery, possibly due to its efficacy in blocking the sympathetic and somatic components of pain. Thoracic paravertebral block carries potential risks such as pleural puncture with or without pneumothorax, hypotension, vagal reaction, epidural and vascular spread of local anesthetic, which may be underreported. Modest benefits should be weighed against the potential complications of this block, and in addition, as a deep block, it should be avoided in patients with coagulation abnormalities. As an advanced technique, the thoracic paravertebral has a steep learning curve and demands a high level of expertise and patient cooperation, whereas the SAP block offers simplicity and be performed after anesthesia induction, enhancing the patient's experience. Therefore, the technique offered to the patient will depend on various factors like the surgical extent, available resources, and the patient preference. The limitations of the present meta-analysis is there is a high degree of heterogeneity in the various outcomes, with the possible reasons being the clinical heterogeneity regarding the depth of SAP block technique used, the levels of thoracic paravertebral block used, the dose and volume of local anesthetics used, differences between the type of surgery and the type of postoperative analgesia. Many of the included studies were small, which decreased their effects, limiting the external validity of this meta analysis. The sample size for a definitive answer for relative analgesic efficacy would be much larger than that of the included patients. Therefore, they concluded that the evidence suggests that both the blocks have comparable analgesic efficacy in breast surgery population, whereas the paravertebral block is associated with marginally better analgesia outcomes after thoracic surgery. Therefore, clinicians should weigh the benefits of thoracic paravertebral block with the complication rate and their expertise in deciding on the analgesic technique to be used. Thank you so much.